I don't know who you are. I don't know what you want. If you are looking for ransom, I can tell you I don't have money. But what I do have are a very particular set of skills. Skills I've acquired over a very long career. Skills that make me a nightmare for people like you.
I know to some of you, the story that I'm about to explain to y'all gonna sound like I'm being cocky, boastful, or to my own horn, but who gives a fuck? Because guess what? At this grown fucking age, y'all should normalize patting yourself on the back. Every day a star is born. Clap for me. Clap for me. And even if you don't clap for me, I'm gonna clap for myself and I'm gonna encourage myself. But let's get down to the nitty-gritty of what I gotta explain to you guys. So these set of skills that I have acquired over 17 years of nursing, you understand? Doing anywhere from ED, PCU, step down, working on wherever they float me at, okay? They don't call me the GOAT for nothing. And for those of you who don't know what the GOAT is, I'm the greatest of all times. And guess what? If I sat and I applied myself and I went and I bust my ass and work hard for all these accolades, and guess what? I'm gonna celebrate myself. If this video, advisory, if this video gonna make you feel some type of way simply because you have not arrived yet with your own personal identity or knowing who you are as a person, then guess what? Go ahead on and skip this bitch, because guess what? This for the ones that want to be stimulated. So what I'm about to show you right now, at this particular hospital that I was at, ED don't call no report. They just dump patients. And then when you have underdeveloped, because I'm not going to really just bash the charge nurses, when you have an underdeveloped charge nurse who lacks skills about how to use the system, meaning bed prioritizing, then guess what? If I'm the only nurse discharging all the patients, then guess what that means? That means I'm going to get all the patients back. So I got 3 patients within a matter of 5 to 10 minutes apart, right at the change of shift, no cap. But this one particular patient that I received, I went in and I checked the history. I always go look my people up. FYI, new nurses, when you're about to get a patient, don't leave it up to nobody responsibility. Don't leave it up to it being nobody, responsibility for you to know about that patient. You the one gonna be taking care of that patient for 12 hours, so you need to go look the patient up and see if it's appropriate for you and if it's within your scope of practice. If not, you have a right to refuse an assignment according to the Nurse Practice Act. They can't argue with you with that. And if they're forcing you to take a patient, then guess what? You need to take it up the chain of command. So anyway, back to what I was saying. Patient come in. Patient clinical manifestations was very superficial. However, I read that the patient drank a half a gallon of vodka a week. So when the patient came, I was already thinking DTs in my mind. Some things just go together, y'all. It would never change. Some parts of nursing would never change. Alcohol, ETOH, CIWA, Q4, clinical manifestations gonna be diaphoreticness, agitation. It just basically depends. And sometimes DTs don't show up right away. Sometimes they show up later. But as a nurse with experience, you just want to be proactive. You understand? The electrolytes gonna be off. They just been drinking. They ain't been doing nothing but drinking. Stomach is fucked up. Liver fucked up. You understand? Our liver is responsible for detoxifying shit. So if you drinking your liver away, there are lysosomes in our liver. If you kill those lysosomes, then guess what? There's nothing there to help you fight nothing. Bitch, you're just exposed. Yeah. So anyway, back to what I was saying. I started to notice at the change of shift. Just think about if I was a new nurse and how overwhelmed I was with them giving me all them patients, and I didn't know how to handle pressure, 4-quarter pressure, because that's what that was, 4-quarter pressure. Just imagine if I wasn't able to handle pressure. I would have just left, not knowing the clinical manifestation signs and symptoms of withdrawals or nothing. But because I looked at his electrolytes and saw the potassium was 2.9, and I seen a little fidgeting, slight agitation, and slight mullet skin, like diaphoretic, I went ahead on and scored him and gave him Ativan. Don't you know when I came back this morning, they ended up giving him Liberian, had to score him 19 plenty of times. Only thing I'm thinking in my mind at that point, Presidex and phenobarbital. I couldn't wait to see the doctor. Guess what? I went in there starting to nudge him. He only responded to pain. When he first came in, he was able to have a conversation with me, walk to the bed, all that. That's a whole acute change. So guess what? Now I'm at the doctor neck. As soon as I seen her, I say, hey, how you doing? I say, he need to be transferred to the unit. He need to be started on Presidex and phenobarbital ASAP. She said, well, let me go assess him, Sonya. Have at it. I watched her through the same window where I'm looking at right now. She came back out. She said, I'm about to put in the transfer orders and put the orders in for him to start on Presidex and phenobarbital. GOAT. Bitch, greatest of all times. Yeah. Thank you. And thank you.